Kathleen Rutledge. Welcome to the webinar. Tonight our topic is Explore the Latest Technology in Prophylaxis. We're going to be talking about 3 major breakthroughs in technology that help the services that we provide, whether we be dentist or hygienist, in the hygiene department. The intraoral camera and its many capabilities, piezoelectric ultrasonics, and air polishers. So what we'll discuss today are the advantages of having an intraoral camera that captures clear magnified photos and also serves for caries detection and identifies periodontal inflammation. Learn what dual-purpose air polishing is and its indications for both coronal stain removal and subgingival treatment of periodontal pockets with a glycine-based powder mix. Discover the latest features in piezoelectric ultrasonic scalers, and then tying it all together at the end with realizing the dental professional's role in utilizing all these new technologies in private practice. So let's start off first talking about the methods of finding decay. The good old explorer, as we probably all have experienced, and again, both dentists and hygienists, even the sharpest explorers now seem not to be able to penetrate, as this picture here will show you, into the areas where the softness is in the decayed pit and fissures. And this is mostly due to, I believe, and in speaking to many of my employers and consulting clients, the fluoride generation, as we call it. These teeth are just so fluoridated that it's hard to get into these pit and fissures like we conventionally used to be able to. We also have transillumination, and that's really great for anterior teeth, as the picture here would show. A little bit challenging on the posterior, but can serve very well for anterior teeth. And of course, we have good old radiographs. You can see here as we spot this out on the 2 premolars here, how easy it is to find decay on radiographs. And then we do have the intraoral camera, where we have obvious things that we can take a picture of and show the patient, cracked fillings and teeth that need crowns. Most impressively get that message across to patients because, as we know, a picture's worth 1,000 words. Now, there's 3 types of cameras that are on the market here, and they do quite some amazing things, quite honestly. I've been in dentistry 34 years, and I never thought I'd be able to practice the way I'm practicing now. The technology is really amazing. Let's first look at Sopro Life. This camera uses blue LEDs, which emit light with a wavelength of 450 nanometers. What happens with this technology is the wavelength excites the collagen, which in reaction sends a fluorescent lighting. The Spectra does something similar. It uses blue LEDs again, but it has a wavelength of 405 nanometers. But this technology uses the wavelength to excite the bacteria present in dental plaque, which in reaction sends the dental fluorescent light, signaling us that there's decay. And then, of course, there's a Diagnodent that has a laser diode that generates a pulsated light with a wavelength of 655 nanometers. And what this does is excite decayed dental substances, which in reaction send a fluorescent light. So all 3 of these technologies are very, very helpful for us to help to find the early lesions, especially in our patients in the years between like 10 and maybe 25 years old when they're going through ortho and things like this. Very, very beneficial, especially when we can't take x-rays when they are in ortho and you can kind of scan the occlusal surfaces. But the next step in finding decay is something really exciting. It's called autofluorescence. What happens with this technology, it illuminates the dental tissue with a wavelength of light between 440 and 680 nanometers. And what happens is the exposed tissue absorbs the energy and reflects it in a fluorescent form. And the obtained images, fluorescence are analyzed, and it's superimposed over the anatomic images. Otherwise, this would be invisible under just, your direct white light. It utilizes the fluorescence technology to do a couple things. It'll illuminate dental tissue to reveal caries, and it will also, in another mode, which we call perio mode, it'll help you to find plaque and calculus. So this is revolutionary. So by utilizing the absorption properties of the blue light, it differentiates the color of the tissue. So there's 3 different settings here on this camera. The technology has the caries mode, perio mode, and daylight, and they both utilize different LEDs. The caries mode has the 3 blue LEDs. Perio mode actually has the 3 blue LEDs, but it's coupled with the white LED, 4 white LEDs. And daylight mode, which basically is just your plain intraoral camera, that's just using the 4 LEDs that are white. So you get all this with this camera. You get the first thing here I'm going to point to you, you can get the portrait or the smile of your patient. Many offices are doing that for patient identification now, so charts aren't misconstrued between juniors and seniors and patients with similar names in the practice. Intraoral shot, which many hygienists use the camera on capturing 1, 2, or 3 teeth. Then you have the 1-tooth shot, and then it can go into macro level, which, if you can get an idea, this is actually looking at interproximal between 2 amalgams here. So it's really quite detailed, has a great depth of field. Now the Sopro Touch is really nice on this camera because all you have to do is slide your finger across the Sopro Touch located on the handpiece, and it freezes any selected images right on your computer screen. So you don't have to worry about pushing hard where you have to click down on a button and it would kind of shake your image. You don't have to worry about trying to find a rheostat on the floor. So it takes really simple images without any kind of distortion. And a really nice feature of this camera, which I love, are these, I call them hoodies, but they're called Sopro tips. And what happens is the tip goes over the intraoral camera lens, and it isolates all the external light so that the fluorescent mode is used just in an isolated form, so you get very, very clear pictures. And what's nice also is the tip is autoclavable. So let's talk about caries mode. This is really cool. When you discover caries, you basically use this camera and it turns the patient's mouth black and white. I always say to my patients, we're going back in time now. We're going back to when I was a little girl when there was just black and white television. And their whole mouth turns black and white. And if you see any black or red, that's a suspicious area for decay. And any gray or white is healthy tooth structure. And to be honest with you, what we find is if there's pink in the grooves, it's usually a sealant. As it gets a deeper pink or more pink, we might be going to an air abrasion technique. And when you actually get into a really deep red and black, you're getting into caries. So here's just a live picture of what it would look like just with your daylight mode or just with the intraoral camera with the magnification. And we're going to assume that the Explorer doesn't stick in these grooves. There you can see there's a little stain, but it's not really a red flag to me anyway if I was the hygienist looking at this. But you can see what happens when you have this technology. Every dentist is different, and I would say most dentists would diagnose that as a sealant. They would clean out the grooves. Some of them will clean it out with an air abrasion first and then do a sealant. Sometimes they have to kind of switch up, and if one of the grooves was a little bit deeper and they had to go into a composite restoration, well then certainly once you get in there you can see that as well. So it is up to the clinical judgment of the dentist. This is just an aid, it's not a replacement for diagnostics. Perio mode is really cool for the hygienist. It helps you to discover deposits that are on patients' teeth. When you see something that's yellow and orange, it's calculus. If it's grainy and white, it's plaque. If you see a magenta color, it's gingival inflammation. And this is far better than what we used to do in hygiene school where we'd stain a patient up and it would get all over their clothes, and patients didn't like that. They leave with really pink gums. So you don't have any of this when you use this technology. I'd like to share with you, this is a case I did, and this is a real great tribute to what this technology can do. If you can see here, this before picture was January of 2013, and this was a scale and root plane patient that I did periodontal therapy in this area, used ultrasonics, placed Atrodox. It was a 6mm pocket with bleeding and inflammation. At the perio maintenance appointment, as you can see with this slide here, when I did my probing depth, I wasn't too happy. I got a 5. It's like, well, a 5 is improvement, and I'll take a 1 millimeter gain, granted. But I wasn't too thrilled. But I guess what got me really excited is I saw, because I had the comparison of the before and after technology, is the great reduction in inflammation, and that's such a big help in us being able to measure our success, as well as knowing that the patient's body is actually being much less taxed now, talking about C-reactive proteins and, the whole systemic link. This is a great advancement. So I didn't just have the measurement of less plaque, less bleeding, 1 millimeter of increase, but I actually had this picture and also to share to the patient and having the record. So this was a real aha moment for me, is how this technology could be beneficial for me in my periodontal therapy cases. Here's another one before and after. Here the camera's in perio mode, so you can see the band of the magenta there. And this is, before SRP or periodontal therapy, and then 1 week afterwards. It's a huge improvement. So all we had before was really looking at, we could make our clinical notes for tissue response, less bleeding, and the tissue is less boggy, and it's, not beefy red, and it's coral pink, and we had all those notations. But pictures just help so much more in showing a patient the value of our services, outside of seeing what we're actually doing for patients and kind of giving ourselves a pat on the back. I really, really enjoy this technology. I also use intraoral cameras to help with training. I teach a lot of my clients to place atridox, and another beneficial advantage to having the magnification and capturing pictures. This actually was a hygienist I trained in the morning. On this side, she placed on the lingual of 9, 10, and 11 atridox, and she didn't do it wrong, so to speak, but you should really have the atridox placed more subgingivally. It's really material that's wasted, and it would be less able to bioresorb easily. So when the patient came back in the afternoon for the other half of the mouth, look at that big improvement in technique, because she placed atridox subgingivally on teeth number 8 and 7 and 6. So that was a really nice way to use an intraoral camera, not only to, teach our patients what we're doing, because we did show the patient this, but for me to train hygienists. Let's talk a minute about air polishers. There's a couple really good ones out there. I chose the most popular ones to talk about tonight. Hugh-Freedy and EMS teamed up, and they have the Airflow Handy 3 and Airflow Handy 3 Perio. 2 separate units by the same company. NSK has Prophylaxis, Acteon has the Air and Go, and Cavo has the Prophylaxis. Let's start with Cavo, because they were the first portable air polishers on the market, and they come in 3 colors you can see there: green, purple, and black. They were the only completely sterilizable unit that offered air polishing. They only have 1 handpiece, and it offered supragingival functions only. The cannula could be easily removed for cleaning and sterilization, and the powders did come in 4 flavors: orange, berry, mint, and cherry. Then we had Prophylaxis by NSK and Periomate. These are 2 different units, and I apologize right here. This is actually blocking these words here. I'm so sorry. I was trying to show you some different angles here, and I didn't move this correctly before I saved my PowerPoint. But this is a lightweight handpiece. It comes with a short and a long nozzle. It's an easy 360 swivel. Quick connect to the major turbine couplings. It's autoclavable after you remove the powder holder cover. That's this part right here. And the 2 different devices are this one here. These are both the same. It's the Prophylaxis. That's for supragingival cleaning. And then you have Periomate, and that's for subgingival cleaning. And this is safe, as the picture shows, subgingivally and around implants. Next we have Hugh-Freedy and EMS, and they have the Airflow Handy and the Airflow Perio. Again, one company making 2 different devices. One, again, the top one here is for supragingival or coronal polishing, and then the Airflow Perio is for subgingival, and that's this one here. The best way to recognize it is you can see the little tank here is a different color. The nozzles actually are. This picture isn't big enough for you to see, but what's neat about this unit is it does have disposable nozzles for the Airflow Perio, but they come unsterilized, so you have to make sure you sterilize them before use. And then we have Air and Go by Acteon, and this is one device, but it does both jobs. So again, you've got the coronal air polisher, and I'll tell you, air polishing has come such a long way from the Prophyjet back in the 80s. If any of you think that air polishers are like that, you've got to rethink things. It doesn't sting the tissue. That's the biggest thing. I can remember from when I first entered hygiene, it would sting my fingers, let alone the patients. It would always sting their tongue. It would always sting their tissue. It was really, really messy. Now, granted, air polishers are still a little messy, but not as messy as they were back then. But they do a beautiful job, absolutely magnificent job, especially in the interproximal areas, because it's just like I tell my patients, it's like power washing your house. But what's nice about this Air and Go is it is a 2-in-1, so then you can switch out to a graduated perio nozzle. So it has the demarcations on there, like a perio probe, and it'll deliver a glycine-based powder subgingivally. So you just change the nozzle and the powder tank, and the powder tank is changed from a blue to a green. You change the type of powder you put in. You go to the glycine-based powder, and then, of course, you can use it subgingivally, as the photo shows here, for subgingival areas, as well as on natural teeth, as well as implants. And its indication is for reducing inflammation in pockets greater than 4 millimeters during the periodontal therapy appointments, during periodontal maintenance. It attaches easily to a high-speed handpiece. You just need to adjust the water flow. So the protocol for this is you will remove all the calculus, by hand scaling or ultrasonics, or a combination of both. Each tooth and implant must be treated individually. The picture there kind of shows you a little bit better as I describe things with the words. You can look at the pictures. You want to make sure there's no excessive bleeding during probing. I believe that's for better visibility. You want to insert the nozzle to the bottom of the pocket, exerting the same amount of pressure as you would with a periodontal probe. And remember, you would activate now the device with the rheostat once the nozzle is inside the pocket. Then you want to gently move the nozzle upwards towards the tooth from side to side for about 5 seconds without any pressure. Notice the angle. If you'll look, follow my arrow here, the angle is towards the tooth. This is important because some people have concern that with this method, with glycine powder subgingival air polishing, there can be a possibility of an embolism. It can't for 2 reasons. 1, it's a very low pressure, but 2, you're angling it towards the tooth, not the pocket. So your technique is important. The 5 seconds is, with the research, they've shown that the glycine powder within 5 seconds actually creates some cell lysis, and it's a bactericidal effect. So this is a beautiful complement to your scaling, root planing, ultrasonics locally applied. It fits right into that model. Air polisher contraindications. There are several. Patients who have endocarditis, diabetes, and that's because the glycine powder may cause an increase in glycemic levels. For immune deficiency patients, patients who have asthma or bronchitis because of the aerosols that are created in the air. For pregnant and breastfeeding patients, hemophiliacs due to the bleeding, following a course of antibiotic, chemotherapy, or radiation therapy. These patients are already compromised medically, and a patient and the clinicians should wear protective eyewear. Our office, we go to the dollar store and buy the biggest, darkest pair of sunglasses we can find. It just helps with, as much coverage as you can get on the patients. The side shields are very helpful as well. And then just the fact that they're sunglasses just helps with the light control, and it de-stresses the appointment. Now let's talk about a brief history of ultrasonics. In the 1950s, ultrasonics was first kind of like, launched on the market. It was initially going to be used for the removal of decay. And you can see this unit here, big and bulky. And this is actually a picture I got from the internet from a unit in the 1950s, what dental offices used to look like in the 1950s. and I'm dating myself. I wasn't born till the 60s, but I did as a kid go to several dentists that just looked just like that. So maybe some of you are getting kicked looking at that, and maybe others of you that are quite younger kind of think that's scary. But many of us worked under these circumstances and worked with these big ultrasonic units. Now, sonic and ultrasonic scalers gained popularity in about the 60s or the 70s. You can see to the left there you've got your Titan scaler, which would hook right up to your handpiece on your bracket tray. And then you've got your ever popular, as we would always call it, the Cavitron, very popular in hygiene and dental schools. Remember that ultrasonics, way back in the day, which to me doesn't seem that long ago, but it was initially used for the debridement of large pieces of supragingival calculus. That means, and this happened to me actually in hygiene school, if you didn't have a patient that presented as this photograph, you usually would not be a candidate to use an ultrasonic in the 80s if you were in dental hygiene school. I actually I never picked up an ultrasonic until I was in private practice. I never had a patient that qualified. I looked over the shoulder of classmates, and I passed proficiencies in as far as the equipment and answering questions, but I literally went into private practice without any ultrasonic hands-on experience. And that's the way it was back then. So it was indicated for above the gum line pieces of calculus and stain. And even though we had this technology, instruments still ruled. And you do have to have your instrument technique down very, very, very solid to be a good hygienist. Ultrasonic technique protocols have gradually evolved over the past 35 years. And as I've looked back now, it really started when almost like the year I entered dental hygiene school, is when things started to change with ultrasonics. It was not in the curriculum, though, yet. Now, let's see what Irene Woodall was saying in 1985. Now, the hygienists out there in the audience know who Irene Woodall is, and many of you who maybe don't know, she was an icon back in the 80s, maybe even up to the 90s, writing for RDH Magazine and publishing chapters in our Esther Wilkins book, which we call the Bible for our clinical hygiene book. But what she was stating in 1985, and again, she was an icon, the go-to person for any kind of research and the latest of what was going on. The primary criterion for patient selection for ultrasonic scaling is that the patient exhibit large amounts of tenacious calculus. It's not indicated for patients who only have light calculus, since most investigators still advocate root planing following ultrasonic scaling. And I put my little footnote here. This actually, you can find it online, the whole article. Article's called Turning to Ultrasonics in RDH Magazine from June of 1985. It's on page 12. You could probably, I'm sure, find it online. Now let's talk a little bit about ultrasonic technology. That's different from sonic technology, which is the Titan, which is below the 20 to 50 kilohertz. But to be ultrasonic and actually have a chance of breaking through the cell wall or disrupting biofilm colonies, you have to be at 20 to 50 kilohertz. And there's only two technologies that do that. The two types are magnetostrictive, that's your Cavitron, and piezoelectric. Also, kind of key phrases that many articles will coin will be power scaling or accelerated instrumentation, and that's really talking about ultrasonic use. Let's talk a little bit about magnetostrictive technology. Again, most people call that technology the Cavitron, but that's a company name. It's actually a brand name. It's like saying Kleenex for a tissue. So that's many times, I know even myself, I fall into that trap of calling ultrasonics the Cavitron. But ultrasonics actually is two different technologies. And what we're talking about now, the magnetostrictive, which the tips vibrate between 18 and 45 kilohertz. They have inserts which are 20 to 30 kilohertz. They're a fixed frequency. They're pulsating magnetic field applied to metal stacks. And that's, if you can see this picture here, it kind of shows you how it works in here. But the stacks are the long part that we actually, when we bleed the unit and put it into that plastic holder before we're ready to work, that's what I mean by the stacks. And those stacks will flex. And that's how the tip moves. It moves in an elliptical pattern. Elliptical pattern meaning it's like a figure 8. It hits the tooth and comes away from the tooth, hits the tooth and comes away from the tooth. It actually causes chatter to the pulp of the nerve, and it's often perceived by patients as sensitivity. They'll say it's too cold. Most people are bothered by the water or the temperature. And many of my patients, when this research came out, I didn't know what I was going to do when I was reading the research where it said that ultrasonics was so much more beneficial for better clinical results, because I thought at least 20% of my patients really couldn't take they would say it was the water or the vibration even of the ultrasonic, and I had a Cavitron at the time because it was magnetostrictive technology. Now, granted, there's two things. Those of you who are using magnetostrictive and you go back to work tomorrow, if your patients are complaining of sensitivity, there's two things you have to check: the age of your unit and the age of your inserts. Your insert should only last you about a year, and there should be a date stamped on the stacks. When I went to an ultrasonic course years ago, I never knew there was a date stamped on my insert, and my inserts were wavy and I could hardly fit them in, and that was one of the reasons why my patients were sensitive. But once I got new tips, they were much more comfortable, but still there were some people that because of that figure 8 or elliptical movement causing that chatter to the nerve, especially in recessed areas, they just were hand scale only patients. There is a lot of water that is necessary for magnetostrictive technology because the water is necessary to cool the stacks. And all surfaces of the tip for magnetostrictive units are active. Now with piezoelectric, it comes from the Greek word piezin, which means to press or to squeeze. And it's not new technology. It first appeared in 1890, used in physics. And piezo literally means the production of polarized electricity on crystals which support mechanical pressures. So what does this mean to us? Why I put these pictures here is because most people want to pick up their piezo and use it like a Cavitron. And why not? It looks like, it's supposed to do the same thing. It's supposed to take off the calculus easier. But what they don't understand is that technology works differently. And we're going to get, this might be your aha moment for those of you who might be struggling with a piezo that you're like, it's not working for me. It won't take off the calculus. I don't know what's wrong with this unit. I bought my own piezo unit years ago after being, totally a Cavitron girl or a magnetostrictive user, because that's what, I was used to for the preceding 2 decades of my career. And I can tell you, I only had the directions to help me out. I had no one to mentor me, and it was just such a pleasure to use this. I'll tell you a couple things that I like about it. We'll first go over some of the bullet points here. It's a high voltage electric signal. It heats up the crystals. That's how the tip moves. The tips will vibrate between 25 and 50 kilohertz. So again, it's in ultrasonic territory. So it is going to be very profound when getting through that biofilm colony. The tips move in a linear pattern. That word would freak me out. I thought, what does linear pattern mean? Well, look to the side here where I have a picture of a windshield wiper. If you can picture how windshield wipers work, that's exactly what linear pattern means. Or an eraser on a chalkboard, it's the same thing. Little heat is generated with piezoelectric technology. You don't need water to cool any stacks because, again, it's working with this high voltage electrical signal, and these crystals heating up is what moves the tip. So it requires a lot less water, and there is a drop-by-drop water flow. So I think when I calibrate my piezo and I turn my water down to the lowest point before it's off, and I kind of get maybe 2 or 3 drops per second and a nice halo mist, not a gush of water like I was used to with my magnetostrictive unit. So patients absolutely love that. If you have any patients who complain that they're gagging with the water and so forth and so on, you'll love piezo for the less water that it requires. And again, only the lateral sides of the tip are active, and it is like windshield wipers. A piece of calculus, if you imagine it on a root surface, is irregular. So just think of it like the bottom picture here of the ice on the windshield. If you can picture yourself going to work in the morning, those of you who live in the north, you'll know exactly what I mean. If you're listening to me in Florida, you'll have no idea what I'm talking about. So try to use your imagination. But if you imagine when you come out in the morning you put your defrosters on, and there's a coat of ice on your windshield. You put your windshield wipers on, you can see how it clears parts of your windshield sooner than others. That's because there's peaks of ice that are higher and thicker than other pieces. And then there's some that are very, very close and thin. So the windshield wiper is actually shaving the ice off of your windshield. And that's what a piezoelectric tip will do with a piece of calculus. That's why it's so comfortable, and that's why you have tactile sensitivity. So piezoelectric is really great. You get enhanced tactile sensitivity, superior patient comfort. It also supports micro-ultrasonic tips. Now take a look at this tip right here. It looks just like a perio probe, doesn't it? It's exactly the same width as a periodontal probe, only it's a piezo tip. And you can put it down. You can see the demarcations, 3, 6, 9, 12. So you can actually get to the base of the 6mm pocket and thoroughly clean out that pocket. Now granted, with a tip like this, you are not going to combat a huge piece of calculus. That's not what this tip is for. It's for grainy calculus and biofilm debridement. But you can be sure to get into those little crevices that I can tell you, as I've gotten more and more advanced in my career, and I walk the probe around very carefully when I'm doing my periodontal screenings on my patients, you can fall sometimes into a width of bone loss that is just the width of your periodontal probe. How are you going to put a scaler in there? And you know, you're not going to find a big hunk of calculus down there, but don't you think you'll get better results, less inflammation and bleeding, and less chance of any kind of relapse with the case if you could put a piezo tip right down into that defect and blast out all the biofilm? Sure you would. So it really does a lot of really spectacular things compared to the magnetostrictive. And it has no magnetic field. There is that drop-by-drop water flow, and I can't tell you, patients really, really appreciate that. This may be a question that'll come up at the end, but I'll try to address it now. I don't have a slide on this, but most people will ask me, can you use piezoelectric ultrasonics on patients with pacemakers? The basic answer to that is no, and that is basically because research has not come out definitively with that, although there are many studies. I think one was even done with the U.S. Navy that shows that there's hardly any interference, especially because pacemakers are shielded now. So the recommendations on the unit, at least the one that I have, says to contact the patient's cardiologist. And that's the way I go about it. All the cardiologists I ask, they say, well, the pacemakers are shielded, and there's no magnetic field, so some will give me permission. Unless I have written permission, I'm not going there, because for the most part, in as far as legally, I think that most people have apprehensions because of the magnetostrictive units, and I would always err on the side of caution. So always check whatever piezoelectric unit you have. Just look at your directions that are inside, your unit. And again, I think more than likely it's going to say, similar to what I talked about. If you want any more studies, I might have them actually if you want to email me. And I'll give you my email address now because I do talk fast and we cover a lot of information. And those of you at the end, if we don't get your question answered, feel free to email me. It's Colleen, C-O-L-L-E-E-N, at perioandbeyond.com. And the final slide will actually have my contact information. But I just want to put that out there for you because the primary objective for doing these webinars is to learn, to go back to work tomorrow excited, fired up, and to be able to implement what you learned. And there might be a couple nuggets that you need clarification on, and I don't mind clearing that up because we only have an hour and we're covering a lot of material. Now, tongue disinfection, this is something you can do with either magnetostrictive or piezoelectric. This is not something that I invented. I went to a course probably 7 or 8 years ago, and I was taught by the instructor that you can actually remove a lot of the biofilm, the plaque, the volatile sulfur compounds that are on the tongue, because the tongue is a reservoir for bacteria. And instead of just using a tongue scraper, you could actually use a general or a universal tip, as you can see here. You don't want any of the bladed tips or the convoluted tips or the mesial or distal tips. And you just have the patient stick out their tongue And from the tip of the tongue, you do sweeping strokes backwards. This is a nice healthy tongue. There's no coating on it. There's no fissures. So it's a nice example so you can see the cavitation. See the little bubbles there? So you've got mechanical action from the metal tip actually removing the plaque biofilm, and then you've got the removal from the lavage and the microstreaming. So it's a value-added service to add for most, especially your perio cases, but even for your just average adult prophies. If any of you want to view a 7-minute video, I have it on my website which demonstrates this, and you can go to perioandbeyond.com if you want to write this down. It's at the bottom of your screen here, perioandbeyond.com/meeting planners, and you'll get a 7-minute video. It'll kind of, why it's under meeting planners, it's because it's my, when you want to get hired as a speaker in the big meetings like Yankee Dental or the Hinman, they want to see a sample of your speaking. So in my sample of speaking, I talk about tongue disinfection. So you can actually visit my website and learn more about this. If you want a periodontal protocol for tongue disinfection, I have a Word document. You can email me and ask me for it. I don't mind sharing it with you. It's just an attachment I would send you. It would actually give you step-by-step of the verbiage and, you know, why you want to do this for your patients. But this seems to be very popular. My patients love it. Wait till you see the next slide. You won't believe it. This actually I wish you could see in color. I did use my intraoral camera, but once I emailed it to myself from work, because it goes through DEXIS, it kind of changes it like a radiograph to black and white. So it's a little disappointing in one respect that it would be much better in color, but this is the before picture. And it almost looks like thrush, doesn't it? But it wasn't thrush. There was a coating. It was plaque biofilm. And if you were to see the color image of this, it looked like plaque, you know, where it was kind of like, looked like cottage cheese. The patient was a coffee drinker, so it had that stain. Then the patient had done a pre-procedural Listerine rinse, so then it had like a teal blue to it. But all over the top of that were these little yellow dots, kind of look like kernels of corn, really small. So when I did the tongue disinfection, you could see the after photo here. I started at the tip of the tongue, and I just, you know, went back as far, and I go really far back until I get to the circumvallate papilla back there, the ones that are shaped like mushrooms. That's where all the volatile sulfur compounds sit back there. And that's what emits those gases, which causes bad breath. So then I came back up here, and I did the other side, and I went all the way back. To tell you the truth, it was kind of like mowing a lawn. I don't mean to be funny, but it was the most challenging tongue disinfection I'd ever done, because for the most part, you just see stained plaque. You might have some deep grooves and pits and fissures in there, but I've never seen it where there was so much plaque. The patient wasn't aware of it, and when I started to use my ultrasonic, these little yellow pieces that were on top, like little hats on top of the papilla, were popping off. It looked like Jiffy Pop. And when I've come to realize, it was calculus. It was calcified plaque. And so there was calculus on this patient's tongue, tons of it. So if that doesn't convict you to start doing this for your patients, nothing will. The patient was very appreciative, did get to see the before and after with my intraoral camera in color version, and she was just amazed. She had no idea that it was on there. We did the rundown with her medical history. We could not, between the dentist and myself, find out any dietary reasons for this, nor medication. She had a clear medical history. Obviously there had to be some dry mouth going on. But anyway, kind of a mystery, but that can be what you will encounter once you start looking at the tongue and providing tongue disinfection. So now let's talk about tips. And again, with piezoelectric technology, you can have a wide variety of tips. I'll just give you a rundown. There's the unit that I have has 21, I think I'm up to 21, maybe more. It's probably higher than 21 tips, and here's just a sampling of 6, but I've got some that look like periodontal probes, like this here. This one I use for veneers and implants. It's a compressed carbon. This is actually, it's hard to see, but right here, this has a diamond coating on the tip. You can see how thin that is. This is just a universal, and these two down here actually have blades. This one here is like a combination of a 11-12 and a 13-14 curette combined in one, blades on both sides with a toe. And this one is kind of like a combination between a 1-2 and a 3-4 curette. Again, blades on both sides. That's right, blades on an ultrasonic. This is amazing. The tip life is about a year, but I gotta be honest with you, I depend almost solely on my piezoelectric scaler. So I'm using 80% ultrasonics, 20% instruments. My tips only last about 9 months. The average person, though, I think it lasts about a year. So we're just going to talk about 3 different tips here, because like I said, there's 21 different ones, but we actually only have an hour for this webinar. So we've got this, in the intro scaling kit, you've got the number 1 tip, and that's your universal tip. It's recommended for treating simple cases, not anything that's perio involved. For gross supragingival scaling, it's the best tip, though, for tongue disinfection. A lot of times I get questions during the webinar, which tip would you use for tongue disinfection? If you have this unit, a number 1 tip that's shaped just like this, any other units, even if you have a magnetostrictive unit, just look at how this tip is shaped, and that's what you want to get, something with a little bit of meat on it. In other words, so it has some force behind it, because if you're going to tackle like the coating like I showed you in the other picture beforehand, you really want to have something that's going to act a little bit really like a shovel. So you don't want something thin and fragile. You really want something that's going to be able to disinfect the tongue. And you would use it on blue power, which is a higher power. And there you can just see the adaptations towards the tooth. Again, lateral sides. And there shows the tongue disinfection. And then you have the 10Z tip, and I like this tip very much. It's subgingival. It's designed for scaling in pockets greater than 4 millimeters. The demarcations that are here go 3, 6, 9, 11 millimeters. I love it for its slim design and its ability to be used at a higher power, so I can tackle a bigger piece of calculus, something that's tenacious, but it can be pretty far down there in a pocket. It's probably my favorite tip, and I have to say, I have to remind myself, I used to do all the work because I would totally use my hand instruments, and I had to supply all the power. But when you use ultrasonics, you have to remember to let the tip do the work for you, so you're just guiding the instrument tip. And you can see the adaptation here. Again, lateral sides of the tip, and you can use it subgingivally. And again, this is another very, very popular tip. This is the one that's like a curette. The H3 tip, it's for anterior teeth. Many, many hygienists use it for the whole mouth. And actually, you can, in healthy patients that have a big enough, a wide enough opening, you can, if someone has a clean mouth, you can get it around someone's mouth. If you're doing a periodontal therapy case, I would only do anterior teeth and premolars for this tip, but it is shaped like a 3-4 curette, and it has blades on both sides. It's great for anterior teeth and premolars. It's by far the most popular tip in the United States. You use it on green power, so it's a lower power, and you use the same skills that you would as you would when you scale with an instrument. So it's really easy for us hygienists to learn how to use this because you just use your instrument skills. And there's pictures of the adaptation there. So you can see the blade, when you think about it, just like a blade, removing a piece of calculus. With all ultrasonics, by the way, you're working from, and I'll show you with the arrow, the apical part of the deposit and working the coronal part of the deposit and working apically. So that's opposite of instruments. So in other words, if there was a deposit here subgingivally, you're going to start from the top of the deposit and work your way down. It's the opposite technique that we have with our instruments. And the technique for scaling with your piezo is really very simple. You can see these are pictures like before, during, and after. And what this just shows you is you want to keep the tip parallel to the root surface. And again, now look at this. You can actually just come straight on here because as I was telling you, you can do it actually two ways. You can come from the top of the deposit here and work your way down. Or if this isn't, and just, from my experience, I would say that it looks like you can kind of just almost push and pull and remove this calculus. A lot of times, and this looks like in this case, this is probably very easy to come off. But you can look at this picture and you can see how much the tissue it just doesn't have any tissue trauma like it does with an instrument. So again, you can see the way this arrow has it here that you can kind of push back and remove that calculus very easily without that tissue trauma and without sensitivity to the patient. Again, using the lateral sides of the tip, that's where the power is. So we've discussed a lot of things tonight, but as far as ultrasonics, there's a major paradigm shift in ultrasonic protocol. And when you change the way you look at things, the things you look at surely do change. So let's see what Irene Woodall said in 1992. Now that would be some 7 years after the quote that I showed you in the beginning of the ultrasonic portion of this webinar. Ultrasonic instrumentation is now the first choice over hand instrumentation for most patients. This constitutes a major shift in dental hygiene approach. This text has placed hand instrumentation secondary to ultrasonic instrumentation. Now this is in our comprehensive dental hygiene book, the 4th edition. This was a hard pill for me to swallow. I can quite frankly tell you, I was a young hygienist in 1992, only had 4 years under my belt, and I did not know about this major shift. I was not taught this way, and I continued for 20 more years, not knowing to pick up my ultrasonic more. I can honestly tell you that the word has to get out there even more and more. When I lecture, I can't tell you how many hygienists afterwards come up and speak to me how they didn't know the things that I share with them and that they're going to see things differently. Many hygienists are suffering from carpal tunnel and many things with their rotator cuffs and with their so many ergonomic problems. It's just better to pick up your ultrasonic.